Welcome back, everybody, to this week's episode of Colorectal Surgery Virtual Education. Thank you for tuning in. We have the pleasure of having here today with us Dr. Matthew Kalady. He's a professor of surgery at The Ohio State University in Columbus, where he serves as the director for the Division of Colon and Rectal Surgery, as well as holds the John L. Marakas Nationwide Insurance Enterprise Foundation Chair in Cancer Research. He's the director of the Ohio State Colorectal Cancer Center, and also the medical director of the Clinical Cancer Genetics Program. He graduated from Harvard College and received his doctorate from Duke. He completed general surgery training at Duke as well, and subsequently completed colorectal surgery fellowship at Cleveland Clinic, where he's remained as faculty for 14 years. Then he served as vice chairman of the Department of Colorectal Surgery, the director of Comprehensive Colorectal Cancer Program, the director of the Sanford Weiss Center for Hereditary Colorectal Neoplasia. He holds several prominent national positions, including a seat on the American Board of Colon and Rectal Surgery, and he's a trustee for the American Society of Colon and Rectal Surgery Research Foundation. We are very grateful to have him here tonight with us, talking about hereditary colorectal cancer. And with that, we'll let you take it away, Dr. Kalady.
Great. Thank you so much for the invitation. I'm going to stop my video and share a screen. I'm going to go through the talk here, but if there's questions during the talk, feel free to interrupt. I don't know if someone's going to monitor the chat or how things will go here.
Yeah, we'll go ahead and monitor the chat and shoot you any questions along the way.
Great. And what are you seeing on? Are you seeing my slides now?
Yep, we've got your slides.
All right, perfect. We've been doing this forever and still not without a glitch. So thanks for joining on a Sunday night. I know there's probably no football fans here, but it's good to get everyone together, and I'm honored to be able to address this group and be part of the educational program. So I'll spend about 45 minutes or so going over different things, and the main topics that we'll cover be just an overview of the hereditary syndromes, how we approach these from a clinical and diagnostic standpoint, and then that's all kind of tied into how we classify them and what the definitions of the different syndromes are. And then we can't cover everything, but I wanted to cover some of the surgical management, at least of FFP and Lynch, because I think that's what's probably most relevant to the fellows and our program here. Just by way of background, putting colorectal cancer in perspective, colorectal cancer is the third most common cancer and the third most common cause of death from cancer in the United States. It's about 150 cancer cases a year and about 50,000 cases or 50,000 deaths resulting from this. So a pretty significant burden on society. Within that, the vast majority of these are sporadic, and some of these things we can control, some we can't. About 25% are familial, meaning that have some sort of hereditary component, but not necessarily an inborn genetic component that we can tell. And then about 5% of everything is some sort of genetic defect or genetic variant that results in hereditary syndrome, the most common of that being Lynch syndrome, and about 1% FAP. The most important thing is figure out, well, how do we recognize this? You have to know that they exist, and you have to know what to look for to try to make a diagnosis. Otherwise, you'll miss these things. So what are the red flags? I think you're all probably familiar with this, but early age of onset, which early age we're considering less than 50, although we do know that there's a higher incidence of early onset cancers throughout the country, not necessarily from hereditary causes, but from other reasons as well. But anyone get less than 50, I think it might be hereditary. People who have asynchronous colorectal cancer or metachronous primary, those with multiple colorectal polyps, there's actually guidelines that say if you have more than 10 cumulative adenomas throughout your lifetime, that's grounds for getting genetic counseling appointments and testing. If you have extracolonic cancers, particularly endometrial cancer, ovarian, gastric, other things that might make you think of Lynch syndrome. Anybody with a family history of colorectal cancer, and then the MSI high or mismatch repair deficient colorectal cancers. When you think of the different syndromes, I think the thing that we can control, that we get every opportunity we have in the office that we see somebody is an opportunity to take a family history and see, do they have family history? Have they had cancer themselves? Have they had polyps themselves? Kind of, what's the clinical phenotype? What do these look like? Or if someone's already come to you with a colonoscopy report and said they have 20 polyps, so look at that. So how does the patient present? That's the one thing you look at. The other thing is if they had polyps, what's the pathology of the polyps? Can they be adenomas? Are they serrated polyps? Are they hamartomas? Each of the syndromes has kind of a different constellation of colorectal polyps. Then lastly, what's the genetics underlying this? And not the genetics in the tumor, but are the genetics in the germline that cause these hereditary syndromes? And taking these things together puts you down kind of the pathway to think about what these syndromes are. And the way I look at these are kind of broadly classified into polyposis syndromes and the non-polyposis syndromes. Now, the polyposis side, I talked about what's the type of polyp that you're looking at. You have adenomas or hamartomas or serrated polyps. Within the adenomas, you have FAP and MAP, and then more rarely PPAP and NAP, which I'll talk about what those are if you haven't heard of those. Within the hamartomatous syndromes, you have juvenile polyposis syndrome, Peutz-Jeghers, and P10 hamartoma syndrome. And then serrated polyposis, which is not necessarily a hereditary condition or a genetic known condition, but it is a polyposis syndrome that has a constellation of findings that we treat. On the non-polyposis side, broadly, these people are termed to have hereditary non-polyposis colorectal cancer. And within that, you have Lynch syndrome and then familial colorectal cancer type X. And we'll get into these as we move along here. So why does it really matter? It's a lot of kind of alphabet soup and a lot of different things. But making the correct diagnosis allows you to educate your patients appropriately about what to expect, what their treatment is going to look like, what kind of planning you need to do moving forward. It also means you could test the family members for these diseases as well, because a lot of these are autosomal dominant. And so if one person has them, each of their first-degree relatives also has a 50% chance of having that disease. It then allows for screening of patients and other organs at risk. So looking at prevention of cancers and polyps and everything else, and then also early treatment for cancers that do develop. So when you look at the diagnostic approach, the very first thing, like I said before, is that you have to have the clinical suspicion that these syndromes exist and that it might be present in one of your patients. So if you don't think that it exists, you're never going to do the testing. You're not going to figure it out. There are two different ways of approaching this. There's tumor-based screening and genetic testing. And the tumor-based screening, important to know, this is probably what most of you are familiar with, but tumor-based screening is only for Lynch syndrome. It's not for any of the other hereditary syndromes. It just so happens that there are some simple pathognomonic things such as microsatellite instability or loss of mismatch repair that you can screen in the tumor when the patients have their cancer either biopsied or taken out afterwards. So that's one way to do it, and it's immunohistochemistry looking for certain proteins or microsatellite instability within the tumor. But again, it only evaluates Lynch syndrome, not the others. And the genetic testing is basically looking at germline pathogenic variants. So is there something inherently in your DNA that is different or mutated or pathogenic that causes you to have a predisposition to getting cancers? And that can be single gene testing or more commonly now, multi-gene panel testing. Let's just look at molecular screening for Lynch syndrome. Most of you probably have some of this at your hospital already. I don't know if you do universal screening on all the tumors or only certain ones that are requested by the surgeon or pathologist or GI, whoever. But there's two main things you look at. You look at for microsatellite instability. So that's a PCR-based test where they look for certain length of DNA sequences that are in microsatellite regions. And if the length of those things, when they run a PCR-based test, they look for what's the length of that satellite they're looking for. And if the length is different, then it's a different, there's different gene sequence in there. So there's one of the pathogenic variants that's in there, and it shortens or lengthens that fragment. If you have fragments that are not the same length, then it's considered microcellular unstable. It's usually five different satellites they look at, and if two of them are unstable, you're just going to have an unstable tumor. The other thing that's commonly done, and probably a little simpler, is called immunohistochemistry for the mismatch repair genes or the proteins. So the MLH1, MSH2, MSH6, and PMS2 are the main proteins that are responsible for Lynch syndrome. And by doing stains on the resected specimens or on the biopsies, you can see if those proteins are expressed or not. And if one of those proteins is not expressed, you consider to be mismatch repair deficient. So either one of these tests can be used as a screen for microsatellite instability to suspect that you might have Lynch syndrome. But it's important to note that microsatellite instability, mismatch repair deficiency in colorectal cancer, one, is not very common. It's only about 20% of all colorectal cancers. But then most importantly, the vast majority of these are actually not hereditary. Only about 15% of mismatch repair deficiency results from Lynch syndrome. And about 85% actually occurs from somatic changes, which is mostly an epigenetic event, which is MLH1 promoter methylation. So methylation is a normal event that happens throughout a person's lifetime. It's more common as you get older. It tends to happen more commonly on the right side of the colon. And if the promoter sequence of a gene gets methylated, it basically turns that gene off. So methylation of the promoter of MLH1 turns MLH1 off, and you've lost that. And the tumor will end up having MLH1 loss, which is MMR deficient. And that's about 85% of MSI high in colorectal cancer. So when you look at things, then how do you figure out if you have Lynch or not? So there's tumor testing, and each hospital might be a little bit different, but this is kind of the standard thing. Either universal screening or someone triggers it to say that I suspect Lynch, take a look. You can do the DNA microsatellite testing. If it's stable, no further testing is needed, you don't have Lynch syndrome. If it's MSI high, then you look and see, okay, which protein is lost. A lot of people won't even do the PCR part. They'll just go right to IHC expression. So if you're deficient MMR, again, it looks at what protein is lost. And also, so the next slide will show you why that matters. MLH1 gets methylated, like I said, the other genes usually don't. So then if you have the protein lost, you look for that specific gene and look for the mutation. If you have a confirmed germline mutation, then yes, it's Lynch. If you don't, then it's not Lynch syndrome. And then I think my fellows asked this as well too. If you have, what's the idea of MLH1 loss? What do you do to kind of sort that out? Well, it's these common MSH2, MSH6, and PNS2 do not usually get methylated. So you go right to testing of that. And if a pathogenic variant is found, it's Lynch. What if it's MLH1? Well, MLH1 gets methylated for the most part, like we said. So pathology labs can test for MLH1 methylation or BRAF mutation, which is usually the inciting mutation that causes or drives colorectal cancer within these serrated methylated tumors. So you can look, if it's methylated, then it's sporadic. If it's not methylated, then you go to germline testing. Or you can test for BRAF mutation, and if it's a wild type, then that also is, if it's mutated, then it's probably sporadic. If it's wild type, then it's not associated with that type of tumor, and then you go to germline testing on that. So that's the kind of algorithm for Lynch on those things. But as I said, there's a change paradigm now, and there's a lot more out there than just Lynch syndrome, and people are starting to realize that. So those multi-gene panels are becoming much more available, much more usable, and they have broader genes, somewhere from 20 to 80 cancer-related genes that can be in a single panel. It's deep sequencing to look at these things, next-generation sequencing to pick up all these different genes. It's becoming much more affordable and actually even probably as cost-effective as using a single gene or as doing any of the other protocols to try to figure this out. And actually, multi-gene panel testing is now incorporated in the NCI guidelines for a lot of tumors. So instead of waiting before we do all this detective work to say, what's the family history? What's the clinical phenotype look like? What do I think this is? And then testing for one gene or figuring this all out now, it's almost more of a shotgun approach. We think there's something going on. We do a multi-gene panel test. Then on the back end, you have to figure out how do you interpret those results and what actionable items are there from these results you can actually make a difference on. So I wanted to present some of the data looking at this and how this has kind of become more into vogue and into practice. So there is an Ohio Colorectal Cancer Prevention Initiative, which is across the entire state of Ohio, looking at about a little over 3,000 cases of colon cancer, colorectal cancer, from 51 different hospitals. And they analyzed a lot of different things here. Everybody got mismatch repair testing done on all of those tumors. And that's, again, they showed about 3% of all colorectal cancers have ended up being Lynch syndrome, which is what you'd expect, and about 20% have the MMR deficiency in them. This first paper, though, looked at what happens just if you look at everybody who's less than 50. So of that whole population, there are about 450 patients who had colorectal cancer less than age 50. For all of them, multi-gene panel testing was performed. Of that, 16% were found to have mutations or pathogenic variants. And of those 72, 33% did not meet any genetic testing requirements. So if you were just going on clinical guidelines or clinical suspicions or everything else where you would start, okay, these people need to get multi-gene panel testing, you would miss 33% of all those patients. And essentially, from that, the recommendation was that patients with colorectal cancer less than age 50 should undergo genetic testing with multi-gene panels. And that was about back in 2017, and that's been incorporated now in the guidelines for several years. So the same study, just looking at a different subset of these things. So again, 3,300 patients, 51 hospitals, all of them had screening for MMR deficiency. And then for people less than 50, that's included here, so it's a little bit of overlap. But if you are MMR deficient, if you have multiple primary tumors, or your first-degree relative had colorectal and endometrial cancer, that cell population, regardless of age, also underwent multi-gene panel testing. And the results were pretty remarkable here. There was 1,462 patients all on the gene testing. 16% of those tested had pathogenic variants in one of the cancer susceptibility genes. 142 were in an MMR gene, and 101 were in a non-MMR gene. So if you tested for only MMR genes in these deficient patients, you would have missed 18 non-MMR pathogenic variants, or 73.3% of all the total. So again, just looking at Lynch syndrome, you'd miss other things. And then if you did the universal tumor screening, kind of what we talked about in the first part, doing the IHC and then going down that pathway, you would have missed 38%, all of those, including 6% of patients who actually had Lynch syndrome, you might have missed during that treating algorithm. So from this, that study concluded that at least 7% of individuals with colorectal cancer have a pathogenic variant, that universal tumor screening alone is insufficient for identifying patients with hereditary syndromes, and now pan-cancer multi-gene panel testing should be considered for all patients with colorectal cancer. And this just came out at the end of 2021, and it's been adopted now into some of the guidelines, or NCCN. So if you look here, again, we already know that anybody less than age 50, go to germline testing. If you're MMR deficiency, if it's yes, also germline testing. But the new thing is down here, even if you're not younger than 50 and you don't have MMR deficiency, still, family history based on evaluation, consider germline testing for Lynch syndrome and other hereditary cancer syndromes. So for NCCN, consider is a fairly strong word. I mean, they kind of hedge on this, but basically, this is now being incorporated into saying you can consider or actually do multi-gene panel testing for all colorectal cancers, regardless of age or family history. And some of the insurance companies now start to cover after this as well. So what happens now with the pathogenic variant? So you do these tests, and you're going to get genes that come back. And these tests are pretty user-friendly. You get a report back that says your patient had, these 86 genes tested, and they found nothing. They found a pathogenic variant in something. So I won't go through each and every one of these genes here, but this is just for your reference for future. When you have a pathogenic variant in one of these genes, it's correlated with these different syndromes. So that kind of concludes the part about talking about the workup of the syndromes and how you kind of get to the diagnosis. And I'm going to spend the next half here now looking at the actual syndromes and then some of the surgical management. So FAP, everyone's probably very familiar with FAP, but it's an autosomal dominant. It's a mutation in the APC gene, that's located on chromosome 5. It happens in about 1 in 10,000 people, and the severity of polyposis varies to tens to hundreds of polyps to thousands of polyps, blanketing of the colon. But we do know that it's about 100% chance of developing colorectal cancer in a lifetime. FAP is also a systemic disease that's not just colorectal, but you can get desmoid tumors in the small bowel mesentery and the abdominal wall. You'd have duodenal adenomas and cancers, CHRPE or congenital hypertrophied retinal pigment epithelium, and then osteomas, such as you see here in the bottom right on someone's jaw. So those are some of the other things you have to be aware of. And actually, the top 3 causes of death or morbidity in FAP is colorectal cancers, duodenal cancer, and desmoids. So moving on, again, this is just going to kind of be a quick litany with one slide on the different syndromes, but MYH-associated polyposis, or MAP, this is something you have to think about. You see people have multiple polyps, but FAP is negative or APC is negative. It's an autosomal recessive inheritance, so you won't necessarily see it in the parents. You'll probably see it more in the grandparents because the parents are both going to be carriers necessarily. You have to have a biallelic mutation in the MYH gene, so you're getting a bad copy from both parents in order to kind of show the phenotype. MYH is a protein that performs base excision repair. So similar to mismatch repair proteins in Lynch, if you can't repair the base excisions or base mismatches, you also accumulate defects. And the varied phenotypes here. So actually you can have MYH and have no polyps, just a single cancer, usually at a younger age. To thousands of adenomas, looks just like FAP. And the mean age of cancer development is about 50 years. Just briefly going over some of the other very rare. So FAP and MAP are rare, but then even more rare. These things have just been discovered in the last 10 years or so. Is polymerase proofreading associated polyposis, which is an autosomal dominant disease also. The two genes are POL-E and POL-D. There's a high lifetime risk of colorectal cancer, 90% if you have the POL-E variant and 50% if you have a POL-D variant. And the diagnosis is earlier too, in the 30s and 40s, also about a 10% risk of having duodenal adenomas. NTHL1 associated polyposis, or NAP, is a recessive trait. So again, you need biallelic pathogenic variants. And anywhere, depending on what you reach, 35 to 78% lifetime risk of developing colorectal cancer by 60. Again, very, very rare. I think I've seen one family of this in my career so far, just being a little bit further characterized. So moving on to the Hamartomatous syndromes, Peutz-Jeghers. Again, these are hamartomas. The kind of pathognomonic thing is this mucocutaneous pigment on the lips. You get GI hamartomatous polyps, and a long stalk polyp, and these things can obviously cause intussusception. Frequently, that's bleeding and intussusception, kind of the main things that you see, and you have about a 20 to 40% lifetime risk of colorectal cancer. Juvenile polyposis syndrome, another hamartomatous, it's autosomal dominant, and 3 different genes can cause this: SMAD4, BMP-R1A, or AIM1. And there's also clinical criteria, which I won't go through here. You can read them, but different numbers of polyps located throughout the tract. And again, a lifetime risk about 50%, again, at a young age for cancer development. P10 hamartomatous syndrome is even more rare, but it's usually a constellation of findings, all with a P10 pathogenic variant. The most common of these is Cowden syndromes, which you have multiple different cancers, including breast, thyroid, endometrial, and renal cell. Colorectal cancer risk is about 10 to 30%. But the polyps are varied too. You get adenomas, but you have hamartomas, inflammatory polyps, fibromas, neurofibromas, and lipomas. So if you see something like this in someone's phenotype or when you're doing biopsies, you're going to start thinking about P10 syndrome. Macrocephaly is also the big thing. So if you're in the clinic and someone has a really, really large head and has some of these things, start thinking about this as well. And then variants of P10 or Cowden are Bedian, Riley, Ruvalcaba, and Gorlin syndrome. Again, similar things, very, very rare. I won't get into those. Moving out of hamartomas to serrated polyps. Serrated polyposis syndrome is a clinical diagnosis based on World Health Organization definition. So the last one was updated in 2019. And this is having at least five serrated polyps located proximal to the rectum. All of them have to be 5 millimeters or greater, and at least 2 or 10 millimeters or more in size. Or if you have 20 polyps of any size throughout the entire large bowel, so colon or rectum, with at least 5 located proximal to the rectum. So you can have few large polyps or a lot of small polyps throughout. Either one of those things gives you a clinical diagnosis of serrated polyposis. It is not a really known genetic thing. There's a small percentage, like I think it's 3 to 5% of people who have serrated polyposis actually have a pathogenic variant in RNF43, but you can't hang your hat on if you have that gene or not, if you have the syndrome. There is an increased risk of colorectal cancer. We don't really have a great denominator, but the risk factors are kind of extrapolated out to be about 20 to 40% throughout a lifetime. And importantly, first-degree relatives have an increased risk of colorectal cancer compared to the rest of the population with a standard ratio of more than 5. So those people start getting screened a little earlier as well at age 40 or so. Okay, so moving on to the non-polyposis colorectal cancers, or HNPCC. So it's another clinical definition, and I want to stress this. There's HNPCC and Lynch are not the same thing. Hereditary non-polyposis colorectal cancer is a clinical definition based on Amsterdam True criteria. These are the kind of 3, 2, 1, 0. 3 or more kindred with an HNPCC associated cancer, and those are listed down at the bottom, things that you commonly know that are associated with Lynch. One of which is a first-degree relative of the other 2. 2 or more successive generations are affected. 1 patient younger than age 50, and then the 0 is that FAP is excluded. Amsterdam 1 was the same criteria, except instead of all HNPCC associated cancers, it was just colorectal cancer. So the recognition of that the syndrome is not just colorectal cancer, but particularly endometrial and other cancers. So it broadened out the criteria. So if a family meets these criteria, they're considered to have HNPCC. Now, Lynch syndrome, on the other hand, and The HMBCC was developed because experts needed a way to kind of group patients together to study them, to figure out what's the risk and what happens when you follow these families, what goes on. So until they found the genetic predisposition or what the genes were that actually caused Lynch, they called it HMBCC. Once the genes were actually characterized, then it was more precise. So Lynch syndrome is actually a genetic predisposition for colorectal and extracolonic cancers, an increased frequency in a younger age. We've said it before, those are the 4 genes that cause Lynch syndrome, characterized by these mismatch repair deficient tumors. People with Lynch can be HMBCC, but not necessarily. Not everybody with Lynch meets the Amsterdam criteria, and not everybody who has Amsterdam criteria has Lynch syndrome. When you look at this, if you take this HMBCC in general, the kind of the endpoint or the entry point is, do you meet Amsterdam criteria? If you do, is your tumor microsatellite stable or unstable? If it's deficient, then germline pathogenic variants get done, and if that's true, then you get a Lynch. You have diagnosis of Lynch syndrome. Also, regardless of what your Amsterdam criteria look like, if you get a germline mutation in one of the MMR genes, you're diagnosed with Lynch syndrome. On the other side of this, and people may not be as familiar with this, but if you have meet Amsterdam criteria, but you have a stable tumor, no MMR variant, you're considered to be familial colorectal cancer type X. So why do we really care about separating those two out? Well, there's different surveillance and screening intervals for Lynch. There's different surgical options. Then we need to tend to potentially affected family members as well. For familial colorectal cancer type X, by definition, when this was originally described, is people meeting Amsterdam 1 criteria, but stable tumors, as I said. Colorectal cancer risk is between the general population and Lynch. It's about 2.3 odds ratio compared to the general population. The age of onset is a little bit older, so between 55 and 60 as opposed to early 40s for Lynch. There's really no data to support a prophylactic or extended colectomy with familial colorectal cancer type X. And the surgical treatment should be tailored to the individual, what they look like, what their family looks like, and their pedigree. But for the most part, people with familial colorectal cancer type X and colon cancer will get treated with a segmental resection. So to summarize my thought process and how I approach these people. So first of all, is there polyposis? If there's polyposis, what kind of polypistology is it? If it's adenomas, hamartomatous, serrated, kind of goes down that pathway to what kind of genes or what kind of syndromes are there, and then the genes will characterize or define what you have. If you don't have polyposis, do you meet Amsterdam criteria or not? And then do you have MMR loss? If no, you go down to FCCX. If yes, and you get tested in your germline, then you're Lynch syndrome. So that's kind of the one way of looking at it. All right. So that covers some of this. I got a little bit more time left. I'm just going to go through, and I think this is probably stuff that might be a little bit more interesting. Say, how do we actually manage these patients in real life? And I won't get into too much surveillance. I'm happy to talk about things or answer questions, but I'm going to talk pretty much about surgical management. So the goals of any hereditary colorectal cancer syndrome management are the same, I think. So it's primarily to prevent formation of premalignant lesions and cancer, remove and treat the polyps and cancer if they develop. So essentially trying to prevent deaths from cancer for all these patients. And then third, but not necessarily less important, is maximizing quality of life and bowel function in all these patients. So anytime we're talking about doing surgery in patients, we have to keep these things in mind. So let's start first with FAP. So the two main issues with, we know it's about 100% chance of getting colorectal cancer. People are going to get surgery sooner or later. So the two main issues are, what's the timing of surgery? When are you going to actually do it? And then when you do surgery, what kind of surgery or what extent are you going to take out? In reality, the cancer risk below age 20 is pretty low. There are case reports. Those people usually will have symptoms such as bleeding or failure to thrive or just a mass diffuse polyposis at an early age. But in reality, it's really, really low risk before age 20. You don't have to do a prophylactic colectomy in someone early on. Usually screens starting at puberty, so that could be anywhere from 12 to 13 or so. And that screening could be either genetic screening, get a test, or start with endoscopy, do a flex sig, and if there's polyps there, then do a full colonoscopy. If there are symptoms or the severe disease, then usually we do surgery at the time of that initial screening. But for the most part, it's reasonable to defer until kind of mid to late teen years or even longer, depending on the patient. So some of the things that delay surgery, I think for the most part, if the polyp burden is reasonable, a lot of times it's a decision by the patient about where are they in their life and when do they want to have the surgery. So a lot of patients will wait to get through high school and say, let's take a break between high school and college and get it done then. Some people do college and then try to get done between college and starting a job. Some people may just say, okay, I'm going to take a break in the summer. But depends on what's going on in their life right now, either professionally or educationally or whatever it is. That is kind of the timing, unless you're kind of pushed to say you have to have surgery now. You can kind of help and work along with the patient and decide what works for them. Patients with desmoid disease is another reason to try to defer surgery, either family history or after the patient themselves already have desmoids. We know that the vast majority of desmoids actually occur after surgery in the abdominal cavity. We don't know exactly why, but it's believed to be some sort of trauma to the fibroblasts and to the tissues, and then that kind of reacts things, or maybe even you have a second loss of another mutation and then desmoid disease develops. So people at risk for desmoids, we try to kick the can down the road a little bit and not do surgery right away. There is a decrease in fertility for people who are having pelvic surgery, regardless of what the cause of pelvic surgery in general. But so for people with FAP, you might need a pouch. They don't have big polyp burdens, but they want to sort of say, I'm going to have family at a younger age, I'd rather not have surgery now. That's a reasonable request. People with attenuated FAP, there's some people that maybe 10 to hundreds of polyps and are not really there. That's in their family. It's something that's based on the G mutation. You could delay surgery on them as well. And then obesity is kind of a relative contraindication, a relative delay or not. If someone's morbidly obese and they're not going to be able to get a pouch, or the surgery is just going to be so morbid, there are different things to do. You talk about weight loss programs. Some people even talk about doing a gastric band or something else to try to help people to lose weight. So it gets into a little bit more practical approach. So then there's indications for surgery. So despite all the different things we talked about, factors of delay, there's things that we need. And there's some absolute indications. One is colorectal cancer, obviously. The uncontrollable polyp burden, meaning you just can't get them endoscopically. There's too many or they're growing too fast. And then symptoms of bleeding or obstruction or weight loss, malabsorption. Those all symptoms have been associated with occult cancer as well. So usually when they happen, this indication to start to do surgery on those patients. Some of the relative indications, increasing number or distribution of polyps. So you're seeing the sizes grow. You're seeing that more numbers all around or becoming more extensive throughout the whole colon. If you have multiple polyps bigger than 10 millimeters, as you know, like anything else, 1 centimeter is about the cutoff. We say they start to get a little bit more high risk. So if you're starting to get multiple polyps greater than 10 that you can't control, that's a relative indication. And then high-grade dysplasia, not absolute, but it kind of starts to push you towards that way. You know that the stability of the mucosa and the adenomers are going to get more advanced to pull the trigger at that point. So the surgical options, and everyone's probably aware of this. So you could do a total proctocolectomy, take everything out, just do an endotheliostomy. You could do restorative proctocolectomy with a pouch, or you could do a total abdominocolectomy and another rectal anastomosis. And this is really, again, it kind of weighs risks and benefits of quality of life and cancer risk. And it's interesting because I think the default for a lot of people is just to take everything out and do a pouch. But if the rectum is relatively spared, an IRA is still a very reasonable option. And if you look at the different things that you think about for complications and risk and everything else, it's a more complex surgery to do, or the IRA is favored there. Sexual and urinary complications are favored. No decrease or very minimal decrease in any kind of fecundity or pregnancy. Less desmoid risk with an IRA, less bowel frequency problems, less seepage or leakage. But the biggest thing is that the future cancer risk is decreased greatly if you do a pouch by taking out the rectum versus IRA. So that tends to outweigh a lot of this, but I think we have to consider what is the real cancer risk and what happens if you leave the rectum in place. So a lot of the surgical decision-making is based on what the rectum looks like. And the number that's kind of quoted in textbooks and articles and everywhere else is basically if there's 20 or more rectal polyps, then people consider what to do with that. If you don't have more than 20 rectal polyps, you could safely do a colectomy in an IRA. If you have more, then the general thought is that you get a total proctocolectomy. Then you have to consider some of the other things like I talked about, obesity, desmoid disease, fertility. Even with a higher polyp number, you could still kind of safely survey or take some of those out without having a big cancer risk. And where did this number 20 come from? And actually, James Church, who was one of my mentors, published this back in 2001. And it was just from observations. He kind of came up with a number and said, Well, what if, looking here, this is extremes. If you have less than 20 in the rectum, less than 1,000 in the colon, and you're not an IRA, at about 10-year follow-up, your chance of getting a proctectomy is 0. On the other extreme, if you had more than 20 polyps in the rectum and more than 1,000 in the colon, and you got an IRA, more than 50% of those people ended up getting proctectomies, some with cancer, some with just uncontrolled polyp burden or symptoms. And if you're in the middle here, about 15% or so with that kind of phenotype, if you did an IRA at 10 years. That's what all this stuff came from, and it hadn't really been looked at. People just kind of took it as gospel to a lot of things that we did, realizing that you might spare the rectum even with 50 polyps, but you can try to take some out and just kind of manage it depending on the clinical situation. But then we looked at more modern data. So one of the things to talk about is before pouches were available, people had a choice of either doing a total proctal colectomy, give you basically an end of the ostomy, or you could do an IRA and leave a rectum full of polyps left in there. So if people had a choice, not the surgeon, but the patient, they say, well, I'll do leave the rectum in place. I don't want a permanent bag the rest of my life. So people who were getting some of these operations weren't really qualified to get that operation. They had tons of polyps in the rectum, and that's why when you read some of the older data, the cancer risk was really, really high. So David Liska, who's at Cleveland Clinic and runs the group up there now for the hereditary group, he presented this at ASCRS last year. And it kind of looks at the modern era. So better patient selection and what do you look at? So if you do these you follow the guidelines of 20 or 30 polyps and you do these operations, what does that actually look like? And you can see on the left side here, of the entire group, 197 people with 13-year follow-up, a median follow-up of 13 years, only 8% required proctectomy at 13 years, or average of 13 years. Only 3% over that whole group had rectal cancer. Of the people, if you had less than 20 polyps, only 6% required a proctectomy, 2% had cancer, and 26% though if you have more than 20 polyps. So, 3 to 4 times difference here, or 4 times different here if you have more than 20 polyps, and you get a higher rate of cancer as well. So that number still kind of holds. And then there's also a study out of one of the big Italian centers looking as well. They use 30 polyps as their cutoff if you're doing an IRA. And again, some of those people had more polyps in that group, but when you look at it again, median interval 13 years, 6.5% of those patients developed rectal cancer. 21% had a 1309 mutation, which is a mutation that's associated with much more profuse polyposis and a more aggressive disease. So having that in itself usually is a contraindication to leaving the rectum in. And a lot of these were young at index. So even in some of the severe situations, using your polyp burden and as a cutoff and doing an IRA can be a fairly safe procedure, and the cancer risk is still pretty low. The key is staying close follow-up with them. The other thing to think about is the functional expectations of an IRA versus a pouch. I tell patients that if you have an IRA, you get 4 bowel movements daily. The stools can be expected to be semi-solid to watery, maybe applesauce at best. You have minimal urgency. You really should have a lot less, maybe even no risk of decreased fecundity or bladder or sexual dysfunction after an IRA. With a pouch, you have about 6 bowel movements daily, mainly watery stool. You might have some seepage at night. You have some urgency. You have some nighttime incontinence for some people. And there is a risk of decreased fecundity and also a risk of increased bladder and sexual dysfunction. So those are real things to consider. So what if you do an IRA, and what's your decision for proctectomy afterwards? First of all, these people get scoped every year, and you could scope them in the clinic. If you have a lot more polyps or bigger things you have to do, sometimes you do it in the operating room under sedation, or you can do it in the scope suite under sedation. But basically, you look at what happens over time. So what's the clinical assessment of the stability of the rectal mucosa? You start having an increasing number of polyps, an increasing size of polyps. You can't control them anymore. You start getting blanketing, or if you do rectal cancer or adenoma with a high-grade dysplasia, it's something to consider as well. And those people will get conventional proctectomy, and you could do an IPAA in that situation. Most of these people, at least in our practice, are getting minimally invasive colectomies and IRA, and then so going back in that situation is not that technically challenging. It's just kind of starting back and just doing the proctectomy part. So pouch neoplasia exists too. So even if you take the rectum out, you got to think about the pouch, and you got to think about the ATZ. This is a study out of the Cleveland Clinic where 165 people with a pouch, again in the pouch era, so 1983 to 2019, meaning follow-up at 10 years. The overall pouch adenoma incidence was 28%, or 28.5%. The first adenoma developed in about 10 years. But then as the longer that you have your pouch, there's an increased incidence of people getting adenomas, as you might expect. And also, if you have adenomas, they tend to progress in both size and number over time as well. Importantly, no cancers were found. There were 2 patients with high-grade dysplasia. So the pouch needs to be surveyed and kind of looked at too. And pouches sometimes will have to come out if you have blanketed polyps or some other things with that. And then the same patient population just looked at another way. This is one of the abstracts, the visual abstracts from DCR. Again, the same 165 patients, but instead of looking at pouch neoplasia, they looked at what is the ATZ neoplasia. Of this patient population, the vast majority had a stapled anastomosis. Again, meaning for about 10 years. Of the entire population, 47% developed adenomas in the ATZ. It was 52% if you had a double stapled, leaving a longer cuff, and actually 21% if you did a mucosectomy. So even doing a mucosectomy does not make you free of getting adenomas and dysplasia. There were, of the whole population, 1.8% had cancer. There wasn't really enough to say if it was different between if you did mucosectomy or not. So 3 of the cancers actually were not being screened. So 6 cancers total. 3 people got lost to follow-up, but then came back with a cancer. Then importantly, 5 patients actually had an anal stenosis due to kind of repeating, taking off either mucosal sleeves or stripping the mucosa or taking polypectomies in that area. If you do that enough, you'll end up getting some intense scarring there and get anal stenosis. So to summarize my approach for FAP surgery, I tend to do a pouch and a total proctorectomy in a pouch if you have more than 20 to 30 rectal adenomas. Again, that's not absolute. If there's other things that considering in the patient's life or their comorbidities, other things that we might stretch that number out. I tend to do double stapled if able. I try to clear any polyps in the ATZ, or if there's no polyps there and you don't rectal cancer, obviously, then I stay with the double stapled and try to keep the ATZ about 2 centimeters. So that's good for function and also for surveillance. And then you need to do anal surveillance of the ATZ and the pouch. All right, so last thing, I move on to Lynch syndrome. Again, like FAP, Lynch syndrome is a multi-system disease, and you have colon cancer, endometrial cancer, ovarian cancer, transitional cell renal pelvis. You can get skin, sebaceous adenomas, duodenal cancer, small bowel, everything else. So everything needs to be looked at. I'm going to focus on the risk of colorectal cancer. And what is the risk? Well, like anything else, it depends. And there's more recent data. We used to say everyone's kind of the same, but we now start to know now that the risks differ depending on what gene is actually mutated. And this came out, published about, a couple years ago now. It looked at male, I looked at age, and looked at what gene was mutated. The 2 most common genes across all Lynch, so MLH1 and MSH2 make about 80% of all of Lynch syndrome. With that risk at 50 years, MLH1 is more about 30 and 20, depending on male or female. MSH2 a little bit less. But when you get out to 75, it's basically 40 to 50% risk of developing colorectal cancer. MSH6 is much different. Really rare to have a young cancer. And the risk at age 50 is single digits and then gets up to about 20% by age 75. PMS2, there's a lot of debate about what the significance of all this is, but the early cancers are less likely and only about 10%. Now, this is all out of European data for the most part. We do see patients in their 30s, 40s, 50s, even in some of our registries with PMS2, so it's not a 0% risk. This is just in their study, though. So what do we do to prevent these things? So the question is, does colonoscopy prevent colorectal cancer in Lynch? And it absolutely does. The recommendation is to screen every 1 to 2 years, starting at age 20 to 25 with a known disease. If you get diagnosed later, then you get screened at that time. Regular colonoscopy reduces the rate of colorectal cancer by 63%. Detection is at an earlier age, as do decrease mortality. That's been proven time and time again. So colonoscopy is really the cornerstone for Lynch syndrome prevention, cancer prevention. When you talk about what are the indications for surgery, then, or when do you pull the trigger on that? So if you have colorectal cancer, that's an obvious one. If you have a high-risk polyp that cannot be removed by endoscopy, just like someone who had a sporadic adenoma, you think about that as well. Someone who doesn't want to undergo regular surveillance So there's these people who come in and say, I'd rather just take care of this. I don't want to come back every year. I don't like doing the preps, and I have a tough colonoscopy. I can't get there. That may be a reasonable person to have a prophylactic surgery on. And then there are very, very rare cases where someone's just kind of cancer phobic and they say, I just can't live with the fact that I might have cancer or I'm at a high cancer risk. I just want it out. And I think after counseling and detailed discussions and risk benefit discussions, you could do colectomy in that situation. So what are the options? Again, segmental versus a total colectomy. If the most common Lynch syndromes cancers are a little bit more common on the right side. So if you got an ascending colon cancer, you can do a segmental colectomy just to right, or do a total colectomy with an IRA as doing a therapeutic surgery for the right colon cancer, but also a prophylactic surgery for the rest of the colon. You say the same thing if it was a sigmoid cancer, you can do a sigmoidectomy versus doing a total. And when we make those decisions, it's essentially balancing, again, like anything else, what's the change in your bowel function, quality of life? What's that going to do to you versus the risk of getting a second cancer? The important thing to realize is that the entire colorectal epithelium is unstable due to that genetic defect. So is more extensive surgery better or not? And some of that's subjective. You have to take a leap and say, none of this is prospective data, but there are multiple retrospective case series that look at this and say, what's the neoplasia? What's the risk of getting neoplasia after getting colon cancer? So some of the bigger series that came out, again, 20 years ago, 16% at 10 years, about 11% at 12 years, 7% at 30 years, fairly consistent numbers of say about 10 to 15% at 10 years is the second risk. There was a colon cancer family registry that has thousands of patients and patients in it from around the world. It was an NCI-funded program where people collate this and you follow them out over time. And they looked at theirs and kind of found there too. The 10-year risk was about 15, 20%, and that goes up over time. So someone has 30 years, it's about a 60% chance out of second cancer at 30 years. So it's important for someone who might be in their 30s, 40s, and they're likely to live another 30, 40 years. It's a really high risk. We looked at this also, hard to believe it's almost 15 years ago now. These are people who we served, they had actually met Amsterdam criteria, not all of them had genetic testing because they're earlier populations. But we just looked at not just at cancer, we looked at high-risk adenomas because we looked at if you're getting scoped and you're getting surveyed the right way, you're going to take an adenoma off that's high risk before it becomes cancer. You're actually limiting the risk of cancer. So we included high-risk adenomas as almost cancer-type lesions or cancers. And if you looked at the people with segmental colectomy versus total colectomy, this was a follow-up of about 10 years. 37% of people either had a cancer or a high-risk adenoma removed at about 10 years after segmental colectomy compared to 13% if you had a total colectomy. So almost triple the rate of high-risk lesions and cancers if you did it. This is segmental. The next question then is, what does the quality of life look like? Well, there's not a whole lot written about this. Some of it makes sense to say, well, if you have more colon, you might have a better quality of life. We looked at this and basically the SF36 questionnaires. This is unpublished data, but 50 people had a segmental colectomy, 45 had a total colectomy, pretty much matched for age and gender. And the big thing to point out here is when you look at the number of bowel movements per day, if you have a total, it's about 4.3 versus 2.6 if it's a segmental at 1 year follow-up. There was really no change in any of the issues in terms of continence or wearing pads or any kind of things in terms of bowel function, just the number. And then when you looked at over 5 years, you did the follow-up on those people, the number of bowel movements essentially kind of equilibrated. So about segmental was about 2.4 and the total ended up being a little bit less. Your body adapts. So there was no statistical difference at that point. So you can tell people that your number of bowel movements won't be that different at about 5 years. Now, rectal cancer is a different story. Same thing. About 20 to 30% of people with Lynch will present as a rectal cancer case index. But the extent of surgery presents a challenge because the function after a total proctectomy in a pouch is very different than a segmental or a total. So essentially looking at doing a proctectomy versus a total proctectomy in a pouch. Again, looking at what's the cancer risk after this, the cancer family registry, the chance of rectal cancer after doing a proctectomy alone was fairly high again, about 20% at 10 years. and then goes all the way up. Look at 25, 30 years, about almost 70% chance of having a second cancer in the colon. That's higher than if you did a segmental colectomy. I think because if you do a rectal cancer, you still have a lot of colon left behind, so you have more colon length and size at risk. Again, stuff we did looking similar to our thing. We looked at high-risk adenomas again after proctectomy, and at about 10 years, it was a 45% chance of having a high-risk adenoma or a cancer. And some of these cancers are actually 2 are stage 3 and 1 was at stage 4 under surveillance. So there's a reasonable consideration that you will have a second cancer. A lot of this might be able to be ameliorated if you have really, really good surveillance, but these are real-world data. So the general guidelines, again, this is from ASCRS as well, treat the rectal cancer as it normally will be treated. So if you need to radiate them, you need to take out whatever you got to do, take care of the rectal cancer. Then the selection of the operation, if you're going to be more extensive or not, should really be individualized, and you weigh the future cancer risk versus the function for each patient. Excuse me. The fact you might have to do radiation and then a pouch after that really gives you a lot worse function, because the bowel that you're making your pouch out of it tends to be radiated and it's not work as well. Same thing, you have to do mucosectomy in certain situations. That function is not as good. So the other thing of this is if the patients, if who do get a proctectomy alone, they have to undergo annual yearly surveillance. The last thing I want to bring up, this is kind of turning rectal cancer treatment for Lynch syndrome on its head a little bit. You're probably all familiar with the immunotherapy trial that came out of MSK, just published in New England Journal in 2022, where they looked at all stage 2 and 3 MMR deficient cancers, and actually most of these I think were Lynch syndrome. And they got immunotherapy, dostarlimab, starting with that first, not doing chemoradiation. They said, let's do this, and we're going to do every 3 weeks for 6 months, and then evaluate them and see how they did. And if you have residual disease, then you move on to standard chemoradiation, and then surgery from there if you needed to. But if you had a complete clinical response, you go into non-operative management, just like a watch and wait, but immunotherapy alone. And remarkably, every one of their patients, at least when they published this series, of 14 patients of them, all had a complete clinical response, and none of them went on the chemoradiation, and none of them went on the surgery. And at further follow-up, at least anecdotally when I talked to some of the authors, this is still holding course. I think the people are doing very, very well. There's very little or minimal recurrence of disease. So the question with that is then, okay, immunotherapy for MMR deficient, which is Lynch. Most of the people are going to respond. Then what do? Do you do surgery? Do you do a colectomy, take everything out because you know you have risk? And I don't think that's answered yet. And I think right now people are watching and seeing what happens. And I think some of this data is going to mature. But it's very reasonable in the era of watch and wait that if you can get a complete clinical response to immunotherapy, that's something you can do. You have to realize that you're still going to be getting adenomas and potential cancers, and you have to pay close attention to keep doing colonoscopies. So it's the summary points from the whole talk. There are many different types of hereditary syndromes, and it all really depends on what the inherited genetic cause is. It's important to recognize, diagnose, and manage these people as individuals and very precision medicine based on the gene defects. And then surgery entails both therapeutic and prophylactic resections, balancing future cancer risk versus quality of life. And our role, I think, is to provide the information, provide education, both to patients as well as to referring providers, and then help these patients make decisions. And then I included just in the slides here some suggested readings. There's an overview, a review of hereditary colorectal cancer syndromes, some things about surgery in there, and then these last two are the clinical practice guidelines from ASCRS as well, including the one that just came out hot off the press, February 24, on polyposis. And with that, I will end. Thank you very much. Happy to take some questions in the remaining time.
Awesome. Thank you, Dr. Kalady. That was an excellent talk. We do have a couple of questions here, some of which came in, and then you had some slides that actually answered some of these. So we'll try to summarize and be brief here because we're right up against the 8 o'clock hour. And are you recommending early and frequent screening in heterozygous MUTH patients? Understanding it's roughly a 7% lifetime risk.
I'm sorry, can you repeat that for me?
Sure. It's in the chat. The chat here has the questions in it as well in case you want to read them. It says, are you recommending early and frequent screening in heterozygote MUTH patients?
Yes. So those people usually start getting screened at like 25 or so and getting colonoscopy. It's fairly rare to find someone who's been genetically tested and not a phenotype. Most of these cases, because it's recessive and it's tough to trace, you don't find that many that don't have something. So a lot of these are actually ascertained on the back end when they present with polyposis or present with cancer. But if yes, you're able to ascertain from family history and get them checked, then yes, you get screened much earlier.
Thank you. So we talked a little bit about PD-1 inhibitors and the recent New England Journal of Medicine trial, and kind of in line with that, what is the natural history for those clinical complete response patients? Do they stay on immunotherapy for life? Do we not know?
I don't think we know yet. Memorial is kind of defining that for us with that trial. I think to keep staying on that, so they stayed on for at least a year, I think, but we don't know what to do yet. It's interesting. It's an interesting time. And we have conversations. I'm lucky to have really, really good colleagues around the country. We sit down and have conversations about this, and we don't really know. So time will tell.
Thank you. One other question that may sort of summarize this here, regarding segmental colectomies for patients with Lynch syndrome. Is there a world in which what's your criteria when somebody presents with synchronous colorectal cancers in the setting of Lynch syndrome? Are you doing an extended colectomy, or have they bought themselves a total abdominal colectomy if they've got two, or total prostatectomy if they've got two cancers at once in the setting of Lynch?
Well, two colon cancers would do a total colectomy, in my opinion. Even one colon cancer gets a total colectomy. I see the one question is, could you just do a right hemicolectomy in a patient with Lynch syndrome? You could. Mm-hmm. Again, it's always weighing out benefit and risk. There are people who, if you have really aggressive stage 3 cancer, there's probably more likelihood that they're going to get metastatic disease or recurrence or something else within the time, instead of them getting a second cancer. So that might be someone who you just do a right on and watch. There are some people who don't want to do an extended colectomy. They're afraid about bowel function, other things. You can do that. You just have to say, this is what the risk is, and you need to keep on close surveillance. So there are definitely patients in my practice who will only get a segmental as opposed to a total. You just have to realize what those risks are in terms of cancer risk.
Excellent. Awesome. Well, thank you so much, and thank you for joining us. Thanks for everybody who tuned in. We'll see you next week on Sunday at 7 p.m. Have a good week, everybody. Thanks, Dr. Kalady.
Thank you very much.